Farzadi, and it's always my pleasure to host and moderate these events for ACN. So thank you so much, Mariana and Co. So I want to start off with a figure, 1.7 trillion euros. That's what Europe spends on healthcare every year. But we know that 9 million people also die every year just from NCDs alone. Most of those deaths, as all of you know, are very preventable. So the question is, why are we spending fortunes treating disease when we know how to prevent? Because healthcare systems weren't really built for prevention, they were built for treatment. And right now they're very much stuck there because of things like reimbursement models that reward intervention, not only detection. And then politically, which our MEP can probably speak to when he does join us, prevention really doesn't also make headlines. You can't cut a ribbon on a heart attack that of course never happened. Also, there is a huge gap when it comes to how everyone is engaging patients, not people, not communities. We wait until people are symptomatic. When they're in the system, we don't reach them in their communities, in their daily lives before they need care. Now, there's one example I think everyone uses, the Angelina Jolie example. When she went public with her BRCA cancer gene in 2013, testing doubled across European weeks because she made prevention personal, not clinical. But that's the thing, this is just a moment. And I think everyone in this room will be trying to understand how do you replicate that moment so it actually becomes a sea change of behavior and action. Now, there was something called a pandemic, which of course no one wants to talk about, but COVID was of course this huge wake-up call. It exposed massive fragilities in healthcare systems. Technology was of course fast-tracked. We all know how all of our GPs now turn to e-consult, which are reigning supreme. You never actually get to see the doctor in person. Is that good or bad? That's another topic in itself. But not much has really changed. The tired and oversubscribed systems that we have in place, where many HCPs are leaving the industry, especially nurses, all of the system really remains largely unchanged. That's why today does matter. 20 years of celebration of putting people first does matter. And also we're here to discuss one particular EU-funded initiative, PROFIT. That program is building a roadmap for personalised prevention. And critically, the Active Citizenship Network is leading the citizen and patient engagement work within PROFIT. Because we know that if prevention is really going to work, it has to be co-created with the people it's meant to serve. So today, there are three really important questions and areas that I want everyone to think about. On a political and economic level, I don't know who's calling me from Leeds in England, but go away. How do we convince the people who control healthcare budgets that prevention is worth funding before, of course, the next crisis hits as well? And then also, as a journalist, I have to add this one in, the geopolitical instability that we're seeing all over the world, supply chains, everything is getting impacted now, jobs, etc. Secondly, the science and the implementation. All of you know that personalised prevention works, but how do we make sure that the system is put in place that it actually reaches people equitably across all member states? And then third, of course, is the system themselves. Do people really understand what personalised prevention means for them? If I was to do a temperature check of people outside this room, I'm not sure if they would actually understand what that means. And for people that are digitally, not really accessing digital tools, they also don't have trust in the system itself. So there is a lot to discuss, and hopefully we will discuss it before the next team decide to check us out this room. So a quick run through today's agenda. First of all, thank you everyone for being here. I know that there was a strike in Brussels. I got here from the Eurostar via an e-scooter. So thank you everyone who has made it here in person. So we're going to have some opening remarks, a keynote address from the European Commission on where personalised prevention sits within the EU health policy. Then we're going to have two presentations on PROFIT results and on the engagement of citizens and patients in personalised prevention. We'll have a Q&A on barriers, challenges, enablers, followed, of course, by the roundtable on personalised prevention, its importance, and, of course, results that we've had from PROFIT already. Audience, there is a Q&A, so have your questions ready, especially if you are joining online. And I can see that our MEP is there. Hello, MEP Brando Benefei. So for the opening remarks, thank you for hosting us, and I will hand the floor to you.
Yes, sorry, just a second. Okay, now I'm ready. So thank you very much for being here another time, another year again for this Patients Day. I'm very happy to be able to host you.
1 second, there's a microphone issue. You're very low.
Okay, it's not me. It's I'm
No.
fine with it.
It's the parliament, we know. There's always a technical glitch. Yeah. Try.
Probably
Could you
for
try
now.
again?
Can I try again? Can you hear me now?
Perfect. Yeah.
Okay, thank you. So I'm sorry I can't be with you in person as usually I am when we organize this recurring moment. I would say a flagship moment in our parliamentary year to take stock of where we are and where we should go to strengthen rights and protections for patients. Also looking in this specific edition at the idea of the personalized care and of tailor-made therapies, which, you know, I've been working so much on AI and digital, can be also fostered and strengthened as a principle by an intelligent use of digital and AI instruments and data. So it's very important that we are here. Again, I'm sorry, as I said, I can't be with you this time in person because I'm in Copenhagen for an international summit about the mental health online of children, which is another emerging topic that we are dealing with in the European Parliament. But we should not lose track of one simple fact, that today we have a large number of people dying or becoming severely impaired in their life by non-communicable diseases that are not treated, not prevented, not detected at the right time. And I think this is something where we need to really change the pace, and also looking at the new multi-annual financial framework that we are now negotiating, we need to be sure that the right instruments with the right resources are there to support patients, to support medical operators, to support the healthcare strategies of each of our member states. And as I said, it's very important that we support the investment in new instruments of digitalized healthcare that can create more custom-made solutions and more personalization of care. These are quite complex issues that need to put together different actors, because we know very well that this is the topic where the competences of the various institutional levels are strongly intertwined. European one, national, regional and local. I think of my own country, Italy, where healthcare is largely a regional competence. So it's very important bringing together, like you're doing today. I want to thank Cittadinanza Attiva and all the co-organizers for having brought such a diverse and strong set of discussants. We will take stock from the discussion of today for the work that we have to do, both on the healthcare strategies at large and for the budgetary negotiations that I was referring to. So thank you very much for being here again, and let's work together in the next months so that what you will discuss today can become a reality for European patients and cancel inequalities of access and create more capabilities at all levels to address healthcare issues for all generations. Let's do this together. Thank you very much, and have a good discussion.
Thank you.
Thank you.
Okay, our next speaker is Daniela Quashia from Cittadinanza Attiva's Active Citizenship Network. And Daniela was also part of the first ever European Patient Rights Day. So congratulations to you. And now over to you to talk about that.
Thank you. And also on behalf of
Cittadinanza Attiva Active Citizenship Network, the organization behind this event from the very beginning. Welcome to all of you. I was there at the first edition 20 years ago, so today really does feel like a milestone and a personal one. 20 years mark a significant moment, not only for because the continuity of this initiative, but because that demonstrates that the strength of the vision, a Europe of health built on rights and human dignity and the active participation of citizens. I would like just to show you something, just a brief recap. Since 2007, to reinforce the principle of the European Charter of Patients' Rights, we have promoted this day as a grassroots initiative, an annual occasion to, to inform, discuss, and encourage concrete commitments to improve these rights across Europe and in the member states. Over the years, it has become a well-established moment in the European health agenda, bringing together institutions like today with the European Commission and the member of the European Parliament, patient organizations, healthcare professionals, researchers, industry, and civil society. And here you can see some pictures from the very first Patients' Rights Day over the years on the other events like today. But this day is not only celebrated here in Brussels. Every year, thanks to patient and civic organizations, together with hospitals, clinics, ministries, local health authorities, and many others, it is celebrated in hundreds of cities across Europe through our conference, awareness campaign, interviews, public debates, etc. This wide participation is a reminder that patients' rights are not abstract principles. They are concrete issues that affect citizens' lives and require continuous dialogue and shared responsibility. This 2026 edition is dedicated to prevention, and in particular to personalized prevention. When the European Charter of Patients' Rights was written in 2002, the very first right was the right to preventive measures. So not treatment, not cure, but prevention first. And today, we are not simply celebrating this right, we are watching it evolve. It now extends, just some examples, to genomic screenings, digital risk assessment tools, and personalized health intervention. So approaches tailored to each individual biological, environmental, behavioral, and socioeconomic profile. But this transformation can only succeed if citizens and patients are recognized as active participants. Without our meaningful and informed engagement, personalized prevention risks to remain an innovative promise that doesn't achieve its full societal impact. That is why events like today matter. They bring together different stakeholders, starting from citizens and patient associations, to understand together where we are heading and what we need to get there. So I'm also here in another capacity as part of the EU-funded project Prophet, where Cittadinanza Attiva contributes with the citizens and patient perspective, focusing on clear communication, trust, and equitable access to innovation. The Catholic University of the Sacred Heart is the project coordinator here with us today. And we also have colleagues from Amsterdam University Medical Center and the European Patients Forum that are key partners in the project too. We are joined online to do the strides by the European Partnership of Personalised Medicine and the European Federation of Pharmaceutical Industries to discuss the broader EU context and the future of action on personalized prevention. So there is a lot to discuss this afternoon. Genomics, data governance, health literacy, equity, the role of patient in research and in governance. And these are not, again, abstract topics. They are conditions to that will demonstrate if personalized prevention becomes a right for everyone or remains a privilege for few. So we are more than 40 people here in person today from 18 countries, and we received more than 150 requests for online participation from 34 countries. So thank you very much to all. So be interactive, ask questions, and share your ideas. Thank you.
I definitely want everyone to be interactive because our next speaker is going to give a keynote address. And if there's time, there'll be space for everyone to, maybe it's not everyone, one person to ask a question actually. And also, you see these two gentlemen with cameras. They're my team. We're also making an event video. So yeah, if anyone has an issue with that, but you're already in the room anyway. But yeah, just to let you know, we are making an event video that will go up on ACN's YouTube channel as well. Okay, without further ado, keep going that way. Well, because she wants to be closer to the slides. Our next speaker is Carmela Plaza Santos. She's the head of Health Innovations and Ecosystems Unit at the European Commission. Please, press.
Hello and good afternoon to everybody. It's such a pleasure for me to be here with you today to explore together the importance of personalized prevention, in particular related to patients' rights. So I'd like to explore with you what personalized prevention really means for us and why we think it's a game changer for healthcare, also for healthcare systems as well, on top of for the patients and citizens. So personalized prevention is, in our opinion, a very transformative approach to healthcare that can be very powerfully complementary to conventional prevention approach. I think we should not forget about the general population prevention approaches. And we think personalized prevention can very powerfully complement. It's not about reacting to illness, but about stopping diseases before they start, or being able to detect them early to avoid heavier consequences. It uses targeted interventions to tailor to each individual's unique biology, environment, lifestyle, and socioeconomic background. And it supports patients' rights. Right to preventive measures, access to screening programs, for example, as we already mentioned, the right to information, clear, accurate, and complete information about your health status, right to consent, right to safety, right to innovation, the access to cutting-edge treatments, and of course, right to personalized treatment, a care tailored to your needs. And I don't know if you know, but Romania has included this right into their law already 2 years ago. So the case for prevention, because regardless of what Mariam was saying, we really need to do the case for prevention. And we think that is, as I was just saying, it's not just beneficial, it's not just a nice to have, but it is essential for the future of healthcare, given the current challenges that have already been mentioned. Rapidly aging population that increases the demand for care, workforce shortage that create a gap between the demand for care and the available staff, budgetary constraints and limited resources. And I agree that the current geopolitical context does not lead to believe that this will change or improve in the medium term, and health disparities that persist across regions and socioeconomic groups, making equitable care a major challenge. So the sustainability of our healthcare systems that are quite important in the context of our European values are at serious risk. And Marian already mentioned the huge chronic disease crisis. This is one of our greatest health challenges today. So we need to act soon and with a lot of determination. But of course, there are good news because research shows that at least 80% of heart disease, stroke, type 2 diabetes, and approximately 1/3 of all cancers are preventable. And this proves the enormous potential of effective care models to transform health outcomes. So, as I was saying, in this scenario, investing in prevention is not a yes or no question, a nice to have, and maybe one day. No, it's really a must. We need to move from taking care of the sick to helping citizens prevent disease altogether, because otherwise we will not be able to really take care of those that cannot prevent any longer. And also very important to mention that in the context of the budgetary constraints, the important amount of spending in healthcare that was mentioned by Mariam is consumed by a very little percentage of the population. So that's also important to keep in mind. So this context positions personalized prevention as a true game changer to complement conventional prevention approaches. It does support a healthcare model shift by shifting from reactive to proactive, by leveraging in the advanced technologies. Some of them are mentioned in the slide. They help identify risk early, enabling proactive interventions and reducing the need for invasive and very costly treatments. But also, and most importantly, by empowering citizens to become active actors in their health. This approach also brings important benefits from a perspective of making mainly the systems more efficient and more effective, because as I was saying, they can stop diseases before their onset or before diseases escalate because they have been diagnosed earlier. And this might avoid complications and long-term irreversible damage. But also, and very important in the context where we are living, it can also help to make healthcare spending more efficient by reducing unnecessary spending. It can be an important ally to bring innovative treatments to the patients in most need by shifting resources from treatly costly diseases in advanced stages that could have been prevented. So we are really convinced that personalized prevention can unlock a revolution in healthcare. So what do we need to do to make it a reality for Europeans? And I think this is a critical question that Prophet Project is answering. They are at the front of the personalized prevention shift. They have paved the way towards integrating personalized prevention into everyday healthcare practice, aiming to become a beacon for policymakers on how to shift healthcare systems from curative to preventive. And I know we will hear more from them today, but later on, but I would like to already commend them for their huge work in the last years. So this EU-funded project is not just a vision, it's really about action. The strategic research and innovation agenda is providing a very clear framework, identify key challenges and prioritizing the short, medium, and long-term actions, and the next steps to be able to integrate personalized prevention. So as funders of this project, we have really a lot of expectations for the implementation by all actors of this roadmap. Because personalized prevention is a priority for us since a while. We have been funding collaborative research in the field increasingly in the last year, fully dedicating topics of Horizon Europe Cluster 1 to personalized prevention. I have mentioned a few there. OpenGS is an example of a pre-commercial procurement project, so really putting the demand side in the driving seat, that has delivered a breakthrough cancer early diagnostic tool based on liquid biopsy. So just a simple blood test with important considerations also of affordability. Or Coro Prevention, Horizon 2020 funded project that is in its last months. It's a flagship of over 20 million euros, which is currently funding a clinical trial for a secondary prevention program for individuals at high risk of cardiovascular diseases. And there's maybe to mention also PredictCom, that is a project that has been funded by the Innovative Health Initiative Joint Undertaking, our partnership with the health industry, and this project is developing currently a screening platform capable of identifying people at risk of dementia before symptoms appear. But much more has to be done in this complex field, as Prophet roadmap indicates, also from the research and innovation perspective. Let me just point at the necessary investigation around gene-environment interactions, or the need to more ambitiously invest to disentangle the personalized levers of primary prevention, is still very much not understood. And also, as it's one of the questions that we have to discuss today, we are very much trying to foster the uptake of the results of projects that we are funding. We are putting a lot of efforts also to our partnerships to ensure that very successful pilots are not just implemented and then put in a drawer. And we believe that for that we need all the actors around the table. So prevention is an important priority for the European Commission. And if you remember in the mission letters, our commissioners, our president asked Commissioner Vaheli literally to step up our work on preventive health. So that is already an indication of prevention being an important political priority in health. And Prophet work aligns very well with critical EU health priorities. Both the European Beating Cancer Action Plan or the Safe Heart Plan highlight the importance of personalized prevention and even point at Prophet as a key source to deliver on its objectives. It's also aligned with other initiatives. I would just mention the European Partnership for Personalized Medicine that facilitates the adoption of personalized prevention and treatment strategies, or the joint action on personalized cancer medicine that recently started, and that is going to implement real-world pilots and use cases to demonstrate the effectiveness of personalized prevention. I think it's important also to mention, even if it's not in this slide, that also from the political landscape, there are a lot of initiatives now that will give a push also to innovation in this sector. Let me mention just the life science strategy that we adopted last year, where several flagships we hope will really foster innovation in the field. Let's think, for example, to centers of excellence for ATMPs, or the biotech act that was proposed in December that will enable notably technologies for personalized medicine, such as gene and cell therapies. Also, the revision of the medical device directive should also help enormously to the uptake of innovations in this area. So I could not like to finalize without recapping some key messages for us. Personalized prevention, like patients-wide, is not like just ideas, it's not abstract, it's a transformative approach with real, measurable benefits. The future of healthcare in Europe cannot be otherwise than preventive for the reasons that were very well described. There is no other solution around this. But we cannot forget about economics and the competitiveness narrative, very important for this commission. But we believe as well that by placing personalized prevention at the core of healthcare, we can also foster a full sector with a lot of small, medium companies that are very important for building a competitive and strong health sector in Europe. So really pushing personalized prevention, we believe, can also help Europe leading global health innovation and strengthen sustainable competitiveness. This vision requires collective action from all actors around the table, as indicated there, but above all, patients and citizens. I fully agree with what was said earlier, because they also need to be a driver for demand for personalized prevention. So I think we need to consider very carefully how to best engage with them and how to best communicate with them. So this should be our vision. Personalized prevention should be a cornerstone of European health policy. It should become the basis of an EU health policy that aspires to be proactive, preventive, and patient-centered. But I think that it's important that we keep in mind that we need also to strongly advocate for the uptake of these approaches at regional and national level, because we can do a lot in Europe to foster, to fund research and innovation, to promote through the semesters to encourage reforms. But at the end of the day, health is a national competence. So I think this is an important aspect to keep in mind. And that's all. Thanks a lot.
So Carmen, then on a positive note, which member states would you say are doing well? Because you brought up, obviously health as a national competence. The European Commission can only do so much of prodding. So which member states are doing well, not just looking at pilot projects, but actually scaling up? Scale is important. And then you mentioned quite a few times the actors around the table. Who's missing here?
Maybe we are missing policymakers. I don't know if you have to say, because for me, I think that we are all convinced about the base of prevention, right? It's not something that we would spend hours to try to convince someone. But I think what we are missing around the table is finance ministers. I think that currently our politicians are, for obvious reasons, very much working on the medium term, 4 or 5 years, depending on their mandate. And I think for prevention, for the uptake of prevention approach, that's very problematic because, what always struggles me is we are ready to invest a lot in things that might eventually happen. Think about all the discussions around defense now. This is not maybe going to happen. This is going to happen. We are going against the wall in the spending of healthcare. If we don't do anything, we will not be able to treat all people suffering from chronic diseases. But we are not doing anything to prevent that, because this seems to be very low. So I think we need very courageous leaders to have our finance ministers and other kind of policymakers convinced that spending in prevention is not spending, is investing. Not only because it's going to allow populations live longer and healthier, well, maybe not longer, but at least healthier and being more productive. That's very important for our politicians. But also because we are going to avoid unnecessary expenses. And let's not forget that today we have 25% of waste in healthcare spending. So,
And that's where everyday people come in then as well.
sorry?
So, and that's where everyday people would also come in, that they be included around the table.
Of course,
Yeah.
of course. There are a lot of spending that could be avoided. And we have the technologies, we have the data, nothing is missing. It's just courageous decisions to move ahead. And I think that it would be better to do it now, that once we don't have the luxury to invest anymore, we are just kind of. So I think those are the probably actors that we are missing around the table. We have the industry, we have the patients, we have researchers, but we don't have some policymakers that for me are critical. And I think that the example of Angelina Jolie is a very good one, but there are many other examples of people that have saved their lives simply because they received the right test before receiving a treatment to avoid, tertiary prevention. I think this is not a luxury today. It should just be a reality for.
Anyone have a question for Carmen? Oh, there we go, yeah.
You're speaking about finances, and when we speak about healthcare funding, it's in fact often sick care funding, funding for sick people. So how do you see from a European level the move of money from sick care to healthcare?
Yeah, it's a very important question. For me, I think that the only thing we can do at European level is to try to push member states for more reforms in the context of healthcare with a view to a longer term situation. I think that's not happening enough. I don't have the right answer for that, but I think you are absolutely right. We need to move away for just looking at healthcare spending as to treat sick people. And we cannot disentangle the decisions about investment in healthcare from the long term. I think that's maybe today something that is probably blocked. And I'm wondering if healthcare spending would be our own, if we would be a company would we do things like that? Would we know that? I'm sure that we could do it differently if we were acting as our own funds, our own budget. So I think it's just looking at it a little bit longer ahead. And probably if we would ask I mean, just by starting saying, let's try to do our most to reduce this 25% of unnecessary spending, and let's put that in prevention. Just by having a kind of objective in the next, I don't know, 5-10 years, we are going to put strong programs in place in order to, that could already be very, very helpful.
Okay, perfect. Okay, yeah, sure, go ahead, yeah.
Yeah, good afternoon. You just mentioned that we have the technology to try. There's also the evidence that, for example, technology like the retina examination with the AI support is really providing clear evidence of early detection of, for example, Alzheimer's or Parkinson in a very effective way. And there are many other screening tools. But my question to you is that basically, as long as we rely on healthcare professionals, we have somewhere a problem, a business case, basically, today in many health systems. So should we not shift prevention to other kind of actors, or at least involve different kind of actors, like community actors, or other kind of, or pharmacists, or peers, in order to have a real shift, rather than just waiting for the GP to take that over?
You don't like your GP, do you? No, sorry, GPs, no one does.
GP since 20 years, so I know them, I love them, but I know what their life is, and and what the business case, especially in the health insurance system, is. And basically, they're not going to spend 25 times in assessing people for neurological conditions if there is no symptom.
Perhaps the GP in the room wants to respond. No. Would you like to respond?
Well, no, just to mention that I think this is a complicated issue, and we are talking about primary, secondary, and tertiary. So for me, healthcare professionals are very important in this aspect. But indeed, there are other actors that probably should be more broad, and we already have very nice examples of further involving pharmacists, for example, for the uptake of pharmacogenomic approaches. We have seen that in Spain, we have seen that in the Netherlands. But even having all the necessary evidence, it's still very difficult to move ahead. So I think that also the work that Prophet is doing about clinical utility, implementation, and in order to provide the right evidence, even when everybody's convinced, still you need to provide more evidence. So that's also something that maybe needs to be reflected. But I think it's a good question, and it's very important to bring other actors without forgetting the healthcare professionals. I think they need to be part of the equation.
And also you mentioned that we need to have the policymakers here in this discussion, and the Ministry of Finances also here, part of the stakeholders, practically involved in this discussion, because they could bring a lot of expertise and their view. We are all convinced as patients, as organizations, as specialists, but what about the practical way to implement this idea?
Yeah, I wonder if they know, for example, so much waste in healthcare. Maybe they don't even know. The last study on this dates of 2017 of the OECD. It has not been replicated, just to say the little importance that is kind of provided. So I think involving them in systems. I don't have the answer on how, but I think they should.
Okay, one more question, and
Yeah.
please go ahead, yeah.
My question is, during COVID, we are alert and we understood how important health is. Are we losing the momentum for all people to understand why prevention and personalized is urgent?
I would like to answer no, but I don't know, to be honest. I think we have to keep doing a strong advocacy, because I don't think it has been forgotten, but I think other things are more. So we need to remind what I was saying. This is not an eventuality. This is going to happen. It's not just maybe, let's prepare in case. This will happen. So I think it's important that we raise your voices, our voices, to help Europe be prepared.
Thank you. I think you've been very generous with your time, Carmen. Thank you. Always good to have someone from the European Commission here. Okay, so you also talked about it as well. Let's go now to profit and the result, strategic research and innovation agenda, and the personalized prevention under profit. So first of all, we have Luigi Rosso from the University Cattolica del Sacro Cuore and profit coordination team focusing on personalized medicine in public health, precision oncology and prevention strategies for non-communicable diseases. Please go ahead. I'll be going that way as well. Look at my back.
I did it. Hello everyone, thank you very much for the introduction. I'm Luigi, I'm a medical doctor from University Cattolica del Sacro Cuore. Today I'm honored to share with you the results of the PROPHET project, in particular the Strategic Research and Innovation Agenda and the Roadmap Personalized Prevention on behalf of the consortium and the principal investigator, Professor Stefania Boccia. So basically, just to give you a little bit of context, PROPHET is a coordinating and support action funded in the Horizon Europe program and it started in September 2022 and is finishing in September 2026. So we are already there. We are almost there. And the overall objective of PROPHET project was to co-create with stakeholders a personalized prevention roadmap related to the research and innovation agenda for the future of healthcare, and in particular to implement personalized strategies for prevention of chronic disease. So this is where we started. We have 18 partners. And I want to take a step back because we talked about personalized prevention also. Carmen talked about what's personalized prevention. So we came up in the very first meeting of the PROPHET project with this definition. And we defined personalized prevention that aims to prevent the onset, the progression, and the recurrence. So we have primary, secondary, and tertiary prevention of diseases through the adoption of targeted interventions that consider the biological information. So we are talking about genomics, but also we are talking about biomarkers, about individual data, environmental and behavioral characteristics, socioeconomic and cultural context of all individuals. So it's a holistic approach for targeted to the single individual. And what we did in these 4 years, we did a lot of things. We started with an extensive mapping of the literature, and you can find, if you scan the QR code, you can find all the results of our activities. And mapping of the literature was to explore all the personalized prevention interventions existing on 4 axes of developments. So basic and translational sciences, policy development, regulation, and also citizen empowerment and patient empowerment. Then we proceeded with an assessment phase. So we developed the PROPHET framework. The PROPHET framework is the principal tool of the PROPHET project, and it aims to evaluate the personalized prevention interventions. And it consists in 3 phases, as you can see. I cannot go too much into depth, but just to give you an idea, we have an HTA phase. So basically, we consider the evidence on the cost effectiveness and the clinical utility. Then we have an HIA phase at impact assessment. So we evaluate the implementation aspects, social equity aspects, and then we have monitoring and evaluation phase. Now we are in the stakeholder engagement and the development of the strategic research innovation agenda. And the final phase of the project will work on the bidding phase. So the implementation in a real world context. So the strategic research innovation agenda, this is a work of 2 years. We started in October 2023 with a concept paper. Then we had stakeholder sessions in Stockholm in October 2024. And we had 5 rounds of internal revisions and then public consultations. And we came up with the final version of the strategic research innovation agenda in October 2025. That was discussed in Amsterdam in a really nice workshop. And finally, last March, so a couple of months ago, we discussed about the SRIA final version, but also the roadmap final version for implementation of personalized medicine, prevention medicine, in Rome in a really nice event. So let's talk about the SRIA and the roadmap. So the SRIA defines 10 challenges that are on the scientific, ethical, societal, organizational, and policy dimensions around personalized prevention. And every challenge identifies the current status and gaps, the priorities, and also the general consideration of each challenge. And while the SRIA acknowledges the importance of all the personalized interventions, we mainly focused on genomics and in particular genomics sciences, and in particular genomics, since they are the most advanced and mature in the field in real world application. Then we moved from a strategic research and innovation agenda to a roadmap. The need of a roadmap was stated also in the European Beating Cancer Plan 21-25. And in this sense, the project answered this necessity. Developing a roadmap. What's this roadmap? This roadmap translates the three challenges into concrete actions, defining timelines, responsible actor, and measurable outcomes. For each challenge, we have a goal, the action to reach that goal, the responsible actors, the obstacles and enabled, the outcomes expected, the initiatives with which to synergize, the funding source, and also the output indicators. So it's really practical, as also Carmen was saying. We moved from a conceptual theories, the strategic research and innovation agenda, to a practical actions to implement them in the roadmap of Profit. And here you can find if you want to scan the QR code and save documents, but also if you go to the website of Profit, you can find all the documents, the mapping results, and you can read the whole documents. So don't worry. So now let's go into deep in for each challenge. I want you to keep in mind that what I will show you are the most important messages that we extracted, but these documents are like 100 pages long. So if you want to go and to expand even more, you can go on Zenodo, you write Profit SRIA or roadmap, and you find the whole documents, and you can read all of them. So for each challenge, we have, of course, title, the actor responsible, that you can find on the right, plus the partners, the gaps, and objective and priority actions. So for the first challenge is the broad scope of promotion and prevention. And basically the gaps here were the healthcare system that are still oriented towards treatment rather than prevention. And there is a weak coordination between healthcare and other sectors and the fragmented preventive interventions. So what we did was the objective to strengthen governance and also to balance investments between prevention and between care, as also Carmen was saying before. And the priority action are to launch pilot projects that integrate health, lab, education, and environment, and also implement funding programs for research to generate evidence and demonstrate value of prevention. The challenge 2 and 3, they were led by us on Università Cattolica del Salvador. The first was on the continuous evidence synthesis system supporting personalized intervention. So basically what we have now, there are gaps in the evidence on clinical utility and cost effectiveness of personalized intervention. And also there is a lack of standardized criteria and frameworks to evaluate and categorize evidence. And what we called for is to develop an evidence classification framework on clinical utility to tier the evidences, and also to create an evidence curation team to manage and maintain a database under the guidance of an expert. The other challenge was regarding the Profit framework implementation. That, as I said before, it is the framework to implement personalized prevention intervention. So we need, there is a lack of shared criteria for assessing the impact of these strategies. And what is needed is to create a network in support of the implementation evidence-based approaches. And to do that, we need to engage ministries and national institutes that have to be partners in this. Challenge 4 was in charge of Elixir United Kingdom and was on data collection, integration, infrastructure. So data are collected in a heterogeneous and non-interoperable way right now, and also regulatory and organizational barriers limits data sharing. And what we need is to develop and implement harmonized standards for genomic, clinical, and wearable data, and also to implement metadata standards and data cataloging practices to make these data sets more transparent. We need the data to evaluate the interventions. Challenge 5 and 6 were in charge of Amsterdam UNC, of Carla, who will present shortly after me, and we're on community engagement and trust, challenge number 5, and on health professional and policymaker on challenge number 6. And basically here, what we can see is that community are not engaged enough, and we need to move from patients to citizens, and from patients to communities to promote personalized prevention interventions. And also the health professionals, they also need to have the right training. As also was saying that the colleague before, we have a problem because not all the clinicians have the time, but also they don't know what to do and they don't have the time to do screening or intervention. So they need to be trained and educated on that. Then we have challenges 7 and 8. Challenge 7 was on the regulatory aspects and synergy with private sector, because we need to encourage private sector engagement through incentives, for example, tax benefits, funding opportunities, and we need to bring these private and public partnership. Challenge 8 was on access, equity, and coverage, was led by European Patient Forum. And basically, we have a lot of inequalities in access to services and also limited involvement of vulnerable populations. And we need to reach them. We need to implement funding programs for patients and citizens' involvement in research to ensure equity and accessibility of prevention to all. Finally, we have challenge number 9. It is on ethical, legal, and social issue, ELSI. It was led by University Ghent. And basically, this is more technical on the application of the GDPR and also on the risk of discrimination related to genetic and socioeconomic information. Of course, we're talking about individual level data. So, of course, there is this risk and also these apprehensions on the matter. And to do that, we need to implement safeguards against misuse, promote inclusive communication strategies, and also implement regulation on data sharing. Because we need the data, but we need that these data are sure and safe, and for all the patients, and also for the healthcare professionals that are working with them. And finally, we have challenge number 10. It is on changing behavior, because we know that today, predictive genomics, but in general, we have a lot of instruments that can predict the risk of people, but then they need to change behavior. They need to adhere to strategies to limit the risk. And right now we have absent effects, or at least risk communication alone is insufficient. And also we have psychological, socioeconomic barriers, limited investments, and to do that, so we need to do more research on acceptability, ethics, and effectiveness of information and health-related choices on pharmacogenomics, but also on lifestyle-related advices, and also develop better strategies to inform also the family members in a confidential way. So I'm really sorry if I went fast. It was difficult to condense 100 pages in 12 minutes of presentation.
You've done really well.
And what's next? Just to give you an idea, now that we have finished, we will go with the national action plans. So basically, we will take the Profit framework and we will put it in real world context, in real world country. In particular, for example, we have Italy, Estonia, and we will try to, building on this RIA and also on the roadmap and the results of these action plans, to build an implementation guidance for the use of the Profit framework to policymakers and decision makers to support personalized prevention as a stable component of public health strategies. So to conclude, personalized prevention does not replace traditional prevention at community level, rather it complements it because it adds more information that can increase the adherence to prevention strategies. It's not a technological issue as we demonstrated in our project, but one of organization and culture. And our Profit project provides a structured guide to support the healthcare systems in this transition. And we hope that personalized prevention can be equitable, sustainable, and shared to safeguard population health and well-being. And I thank you very much for the attention.
And I won't ask you a question, but there was just a little comment on literally the smallest thing that you talked about. And this is where I think confused messaging comes in for everyday people. So you talked about, you know, the forms, the data you need from people. And so I think whenever you do anything, there's a form which says, you know, say what your ethnic background is. So the recent trend has been, you don't have to disclose it anymore because obviously people's backgrounds are becoming a lot more complicated. So again, now you're going to have to revert back to asking people, what is your ethnic background? So there's definitely a lot of work for you guys to do. But before we lose time, Carla, please go ahead, because I think what you're going to talk about, Carla, is from the Amsterdam University, a sociologist examining the ethical and social dimensions of implementing genetic testing and personalized prevention within healthcare. So please go ahead. And if we have time, we'll ask both her and Luigi some questions.
So good afternoon, everyone. My name is Carla Vanel, and I'd like to thank the organizers for having this opportunity to talk about our work. The title of my talk is From Awareness to Co-Responsibility, Engaging Citizens and Patients, because our team was responsible for the citizen evasions engagement workshop. So personalized prevention, I would argue, requires engagement 2.0. So why? Well, we can already build on firm foundations. We know a lot about patient and citizen engagement already in healthcare and public health, but the vision of personalized medicine requires patient and citizen engagement even more urgently. So why is that? Because of all these technological innovations, we've heard about genomics, digitalization, imaging, AI is rapidly progressing. So these techniques produce more data, require more data, and know via these data more and more about our intimate lives, our behaviors, our vulnerabilities, and our susceptibilities. So we can use that data for good, but we also need patients and citizens to think along critically about what kind of data they would like to share, how they would like to consent, what type of information should go into the consent form, such as ethnicity perhaps. And so we need the patient sits at the core of this activity to be active, to see what type of research questions are being able to be addressed, and also how we should manage this kind of healthcare. So not only the research and the care itself, because research and care become intimately connected, but also what policies we need to develop, so the governance. So this new vision of a patient, personalized medicine and prevention, in which genomics information play an important role, our roadmap says, envisions and requires active and informed patients and citizens who take an active role in managing their own health and care. They need to be well informed, to be empowered to make decisions regarding their health and prevention, to reflect their personal values, and be aware of options for contributing to research. Well, that's an ideal version, of course, because we require those patients, but we're absolutely not going there at the moment. So patients and citizens are central in personalized prevention, and they also form the core of the Profit Project. We have a dedicated challenge, as Richie just mentioned, but we also see patients and citizens coming up everywhere. For instance, in Challenge 9 on the ethical, legal and social issues, if we look at the consent form, for instance, and in changing behavior. So we were very lucky to be able to work closely with the Active Citizenship and the European Patient Forum to actually co-create together and work together on developing the Profit work package. So I'm really grateful for that. So as I said, this intertwinement of research and governance and care becomes very prominent, and we did in the Profit Project a scope and review on what type of engagement activities are already going on. So we focused on Europe between 2015 and 2023, mostly on cancers, cardiovascular diseases, and neurodegenerative disorders. And what we actually found was, if you look at what the engagement is already going on in the field of personalized prevention, you could place them on a spectrum. So we used a slightly modified version of the International Association for Public Participation spectrum, which has consultation as a least form of engagement, involvement and collaboration as an intermediate, and public patient-led or directed on the far end. So different methods go with each form. So focus groups can be less intense. If you have involvement and collaboration, you can have workshops or forums to actually have more engagement with each other, and public and patient directed. You can think of dialogues in a more sustainable form, such as taking part in patients' committees, for instance, on biobanks. So what we saw, actually, I'm not sure if it can be seen in the back, but is that the majority of the engagement practices that we found in personalized prevention were one way. So consultation, to ask people about their views, for instance, in focus groups and interviews, and some few examples of involvement and collaboration, and only, well, one more very intense co-created activity. To give you an example, for the research and care field, the consultation, stratified precision of personalized medicine. This was a cancer service in London where they try to interview and do ethnographic work on how the practice changes when you introduce personalized prevention strategies. And below we see an example of a very intense collaboration, which is public directed, an app that was devised and co-created to do a form of citizen science and think of visualizations of DNA fragments and how they could be reordered to actually find patterns. So very broad spectrum of participation in engagement. And most of our engagement practices were in care and, well, a little bit less in research and care, and governance and education, very little. So we try to also do some qualitative work, and that we did with intense collaboration with ACN and EPF towards better practices. And you can find the paper that came out of that over here, and the primary researcher sitting over there, Skeeftenberg, our PhD student, interviewed and did focus groups with patients and asked them what they thought were already going on as best practices and how they might be improved. For instance, in care, it was really important to have clear information also on genetic testing, which is becoming increasingly also being given in mainstream care. So not only by clinical geneticists that have long time to explain, but also ordinary health care specialists. Non-specialist mentors, patient organizations, intermediaries, communities, what Luigi already talked about, should be employed to help there. So research involvement in various stages of the research process from the beginning, very important, include diverse groups and populations in research. As we know, the genomes we currently know about are mostly, for a large part, from people of European descent. So we really need other types of genomes to get more information. And compensation of patients' time in engagement. So also in governance, diverse groups should be represented, and we should make better use of patient-generated data. So we worked closely, and we tried to also give back our results by providing and making a sort of toolbox. And as you can see, we are almost, we're currently collating materials. We have a special page for healthcare professionals, for policymakers, and for citizens and patients, in which we bring all the results that we have from the Profit Project. And we also would like to invite you as representatives of patient organizations, if you have materials for us on what you do to engage citizens and patients, to send that to us, because we want to make sure that it is a resource for the coming years to use, and for people to disseminate also the findings. Okay, so as a takeaway, further takeaways, because we of course did qualitative and quantitative research, but other aspects that really came up. Patient engagement should not be an afterthought, but a structural element of research and all sorts of care engagement. So structural funding is very important also in EU projects. Evaluation of engagement is currently lacking. You can do some form of engagement, you can do a survey, you can do a focus group, but what is explicitly your goal? If you state that, you can see if you actually achieved your goal. So those kind of process criteria could be used to help improve your engagement practices. Improvement of information sharing in effective families. We know, for instance, for hereditary breast and colorectal cancers, the uptake of family members is currently around 40%, which is really a problem. Well, it's not a problem if they make an informed choice, but if they actually, if the information doesn't reach them, or people find it a burden to inform their family members, perhaps they need more support in order to explain the family members and make sure that they ask for advice and go to a clinical geneticist. So that's an area where we can see improvement. More research into behavior change. People can perhaps be nudged because we know if just giving information is not enough. People should have the ability, they should feel in control of the information, and they should not face barriers to actually take up on, for instance, lifestyle advice, personalized lifestyle advice. And last but not least, very crucial, increase health literacy and digital literacy, because all our plans for this informed and active patients really fall short when people do not know how to use these tools, but also people who cannot use the tools, they should still be able to see a doctor or a friendly face to actually enter healthcare. So for effective implementation of personalized prevention, we need meaningful, this true patient and citizen engagement along all ways as a co-responsibility of all stakeholders, also including healthcare professionals, policymakers, and the industry. And with that, I would like to conclude and thank my co-collaborators here in the room and at home. Thank you very much.
Thank you. Question for either Carla or Luigi on profit. Okay, no one wants to talk about profit. Okay, so in that case, I will ask some questions quickly. So you were speaking there about people, you made an effort to include people from socioeconomic backgrounds, lower incomes, ethnic diversity as well, people that are digitally illiterate. But you're creating the perfect case here. How do you make sure that that is the work that you have done, as you were saying, doesn't get lost along the way, that member states don't essentially mess it up, and especially given the budgetary constraints? So are there, perhaps, have you sort of knitted into all of this, perhaps areas for them that they need or should focus on, especially when it comes to, I don't know, certain cancers or certain NCDs, so that they don't actually, that the work you've done doesn't essentially get lost, and that the people that you try to engage with don't get left behind?
Yes, and I especially referencing to these groups that are difficult to reach.
Yeah, so rural areas, people from
Yeah.
ethnic
Yes, yes, we were fortunate to have people also in our focus groups from Eastern Europe. So we got a flavor of the availability of services in other countries, because that's I think a great point of attention. Also, genetic services are not evenly distributed among Europe. So we do think that we could use digital tools to a certain extent. We could refine them. It helps reaching the families, especially when the resources like physician time is low. We could, in an ideal situation, use digital tools to help people spread information also within affected families. That would be cheaper and better if you are knowledgeable on how to use that information. But we know there's work going on to make, for instance, these tools accessible in lay language, and also to program these tools together with patients with lower health literacy. So there are initiatives going on. And otherwise, we learned from our focus groups that community involvement is very important, because, I've said before, the individual patient might not have the capacity, but the community that the person lives in, or perhaps the GP service around some deprived areas, for instance, some GPs really have an important role to actually bring people together. So that's the thing that we've talked about, we luckily encountered in our focus groups. So hopefully that will progress.
Yeah, I think outreach is really important, and face-to-face is important in
Exactly.
rural communities.
Yeah, and some people will never use the digital tools, so you really need to keep the face and the person there for some people.
Thanks. Any last comments from Luigi? Oh, you're good.
I'm good.
You're good. Okay, so let's move on to the roundtable. I know that we're a little bit behind, but I will eat into the audience Q&A. So sorry, guys. But also, if you are joining online and you do have questions, please do send them in because we will come to you first. Okay, so for the panel, we have Yasmin with a surname I won't pronounce, Yasmin. She's on the European Patients Forum working on personalised prevention, digital health and patient engagement with EU-funded projects, including, of course, profit. We have Professor Martina Cornell, the President of the European Society for Human Genetics, and Professor of Community Genetics and Public Health Genomics at Amsterdam UMC. Then we have Matteo Gentili, who's joining online. Hello. Foundation of Toscana Life Sciences and representing the European Partnerships for Personalised Medicine, focusing on cancer prevention and European research coordination. Last but not least, we have Natalie Moll, the Director General of FPA, representing Europe's research-based pharmaceutical industry. Okay, so Yasmin, I'm going to come to you first because you are the person representing the patient voice in the room. From a patient perspective, just how much is of what everyone in this room and everyone working on profit wants to do is actually filtering down to the everyday person. You know, when we look at people sitting in GP surgeries, whether it's Bucharest or Lisbon or Athens, what level of support would you say they're being offered in terms of prevention that perhaps can be scaled up and doesn't become just a kind of Brussels bubble conversation? Is it reaching them?
That's a good question. And looking at my interactions with patient organizations, our members, our communities, personalized prevention, unfortunately, is still a conversation mostly among those who already know about it or who are aware about it. And to give an example, a colleague of mine joined the Profit Project last year with me, and her learning curve about personalized prevention was quite steep. And she came to me and was like, "Oh, I wasn't aware how relevant this is to me and my family." So talking about a person who has a very high health literacy and who sits at the source of knowledge and patient engagement, even a person like that can learn more about personalized prevention. That tells us a lot about the average person's interaction with personalized prevention across Europe. So for me, the message is clear. We need more awareness building, more awareness raising, and health literacy campaigns to start the whole conversation. And in terms of profit, we have been working on a video series to build capacity for our patient communities to sort of start with the fundamentals, the basics. What does personalized prevention even mean? Why is this relevant to me? What does it mean in practice? And we've been working with some partners here in the room and also not in the room on those videos and starting to disseminate. But yeah, it's a very early progress, and these initiatives must go hand in hand with structural changes. So personalized prevention should be more implemented or more the norm, part of routine care, checkups, vaccinations, etc. That every person can say, okay, this is something I should know about and I should follow up on. And that is also affordable for everyone. We have been talking about inclusivity before and equity. And for us as EPF, of course, it's very important to bring everybody on board. We often talk about the 5 A's framework for access, which is availability of the service, affordability for everyone, accessibility for use for everyone, adequacy of the supply of the service, as well as appropriateness for the target populations and their needs. So yeah, there is still much work ahead of us in terms of raising awareness of putting routine practices in actual practice and working towards inclusivity in both policymaking as well as implementation on the ground.
Thank you. And so, Martin, a similar question to you then. Martin has already been brilliant speaking on camera. Do you think personalised care is still a little bit too routine? And how do you then create a dynamic within, whether it's a healthcare system or an individual hospital, to actually make it more mainstream?
Yeah, so I think it's not yet mainstream in Europe because we have many different countries who each have their healthcare system. So professions like clinical genetics are not represented similarly in all countries. So we need those professionals, first of all. But then if you want to make it more mainstream, it's also important that patients know about these conditions like BRCA, like Angelina Jolie, and speak about their family's health history. So you just ask at a party, well, do you know of anybody in our family who died at a young age of cancer or heart diseases? And if this was the case, ask them whether a DNA test was done. And in some countries, for instance, they are using family letters to inform family members who are still healthy, but who would also, well, need a DNA test. And if you just speak about these things, you at least know that things like that occur in your family. And we just heard this number of 40% being tested. Well, if we want more people to be tested for serious conditions where there is prevention possible, then this discussion needs to take place in families. And still a different aspect is that we need to build it more in our health systems. Think about pharmacogenetics, which is also one of the examples in the Profit project, where if you take certain chemotherapy for cancer, there are some severe side effects that might even be lethal, but you have to do, before you give that therapy, a certain BYD test. It's in many of the guidelines, but it needs to be built into our systems. Like if somebody is prescribing that kind of medication, there should be a warning saying, oh, don't give this to this patient because this patient is extremely sensitive and might have severe side effects. So everybody, on the one hand, can read guidelines, but if it's in the guideline and not in the system, still people may overlook it and it might not be done everywhere. And like the example of Italy, they also asked many laboratories whether it's already available in all the regions, and it appeared not to be available equally, even in Italy. But so it might also in some European countries be something that we really need to build the laboratories, but then need to build the warning systems in our healthcare systems, in the registrations, in the automation. Yeah.
I think there's just a little bit too much to do, or at least right now. Would you say we're, I mean, for everyone here, I mean, are we at the start of it all and we're building it up? So perhaps right now it feels like there's too much to do.
Perhaps we need to start. And, if we think it's too much to do and we shouldn't start, we're not going to achieve it anyway. And then perhaps some countries can already give family letters to many people and have clinical geneticists, and a few countries need to start much more there. And for instance, that warning system in the EPDs, in the electronic patient records, is maybe a bit of too much of a challenge for 1 year. But if you don't start, you're not going to have it in 5 years' time either. So yeah, it's quite a big challenge, but let's just start. Yeah. And perhaps some countries will go a bit faster than others, which is never nice because you like to live in the countries with the best healthcare system. But if we don't start, it's not going to improve.
Well, listen, I come from the UK, so yeah. One quick question I would say is there was one thing that you brought up about, families having dialogues. So Yasmin, to you then, yes, families can have dialogues, you can learn the patient history, but then the sharing of the data, where do you store it? Because it all, I mean, that's the question.
Yeah, I mean, this is a larger conversation to have about do we trust and how much do we know about what is being done to our data? So here we really need to focus on also raising awareness about not just health literacy per se, but digital health literacy. Who controls our data, who has access, how can we control our own data, and have that conversation not just with ourselves, but also with our family members.
And Nancy, I know that you also want to talk about the trust that patients have or don't have when it comes to the methods that we're trying to create when it comes to preventive medicine.
Yeah, what I think obviously none of this can happen unless patients trust, or citizens trust that their data can be used and is being used in the right way. And in that sense, I really like what you were saying in terms of maybe we should just start. I think we should just start, but everybody should take the responsibility. So it's not just one group should spend time explaining, we should trust this. It can't just be patient representatives. It has to be clinicians, it has to be industry, it has to be the whole value chain, doctors, nurses, all of those involved need to at least have the training to be able to explain and answer questions, but then build trust. And you never trust somebody that just trust me. You trust if you feel that you
actually do the
you understand and that you have all your questions answered. And I think that in that sense, there's a level of literacy that has to increase, but there has to be a clear action that is part of the I found that word in a different language, not the right one. The trip that we need to take from just care to actually prevention. There's a whole elements. There's a real patient engagement element in that, right? In care, you're in a hospital, I would take care of you. In prevention, I need to decide, I'm going to test for this. I think I did my first DNA test in 2009. That's because I'm a biotechnologist and I'm super keen about it, but it was my decision. Nobody came and said, you should do a DNA test and find out. But I think it's a real education. I don't like that word, but it's a real level of knowledge of individuals taking ownership, but that knowledge doesn't come from the sky. It has to be shared by whoever the right institution. I've started talking about it in schools. I mean, we can leave it up to doctors and nurses, but wouldn't you in a school also start where you talk about biology, when you talk about biotechnology now increasingly in schools, and you share that, hey, you can find out if you have a history of, like I do, lung cancer or skin cancer in your family, your levels of probability are higher, so watch out, don't smoke, don't go in the sun. I think there are lots of levels of sharing information that would increase patient trust, that would enable us to do the prevention we need to do.
Okay, so let's bring in, sorry, I've kept my phone on because organisers are talking at the same time, so don't mind. So lots of key words are brought up there, Mateo: ownership, knowledge, trust. Let's focus on the healthcare professionals. And I know that they do sometimes get a bit of a bad rap. They're also overburdened. So we know that there are lots of challenges, but there are also lots of opportunities for this innovation, for medicine, for healthcare to be patient-centric. But how do you build the skills base when it comes to the healthcare professionals? And especially, do they have the capacity right now to retrain, refocus towards something else?
Do you hear me well, first of all?
I think you're muted.
Oh,
No.
actually not.
No, it's our side. It's our side.
Okay, do you hear me well? Okay, sorry for
Yes,
not
we
being there, but due to the strikes, I could not come. So thanks also for the opportunity of representing the European Partnership for Personalized Medicine in this meeting. So thanks for the question. I think that Europe has the foundations indeed for personalized prevention at scale, but there's actually some mismatch when it comes to workforce and training ecosystem to really operate it in healthcare systems. We have seen also from the words of Carmen that the European Commission is pushing policies and innovation with initiatives like the Profit Project, the EP permit, which I represent, so on personalized medicine and personalized prevention, but also with other initiatives that really gravitate around personalized medicine, like the European Health Data Space and a lot of initiatives around genomics and AI healthcare. This, of course, produces a fast evolution of healthcare systems that are adopting innovative solutions and also transforming themselves in a more, let's say, digitalized version. And the risk is that healthcare professionals are now lagging behind due to their workload and do not have the opportunity of get trained in an appropriate way. Also because to really implement personalized medicine and prevention, we really need a new kind, let's say, of healthcare professional that is able to handle a big quantity of data, but also to interpret them, to understand risk-based models, to also take care of the communication with patients in a thoughtful way also, and making them aware of the uncertainties of the risks and so on and so forth. So you really need to increase the expertise of healthcare professionals at the cross-sectorial level. This is being done also through initiatives and projects like, for example, the partnership which I represent has also launched trainings, summer schools, and different initiatives to really create a sort of cross-contamination, cross-fertilization of healthcare professionals. So the aim is really to get there and to have a sort of new generation of healthcare professionals. Another thing that needs to be also taken in consideration is the huge stress and the huge pressure that these professionals undergo and the risk of burnout. So measures also to take care of their mental health and of their well-being are also needed, of course.
But I mean, Natalie also talks about, doing it differently and, starting at school. So if you're talking about having different kinds of healthcare professionals, then are you talking about, teaching people differently when they, study at university? And then that would then in itself take even longer for those healthcare professionals to then be in the system to provide the care that you need.
I think that, education should start in the university, but also being flanked during the let's say, all the career of a healthcare professional. So the problem is that education is done and training is done in spot moments, while it should be something continuous, because digital evolution, AI is ever changing, is very fast, and we should provide a continuous learning process for these professionals to really cope with the evolution of the healthcare systems. Otherwise, we risk to have very fancy measures and very digitalized healthcare systems, but with people that are not able to operate them in the appropriate way, and that are not able to deliver this evolution and the added value of this evolution to patients and to the society. And we have said several times how important is public engagement and empowerment, not only of patients, but of citizens at large, to really advance personalized prevention in this case.
Are there any HCPs in the room who want to maybe comment on that? That retraining themselves, yeah.
I come from two backgrounds. I'm a patient's representative, but I'm also an HCP. And when I hear a lot about genetics and the need for professionals, I blame a bit myself, because I'm a genetic counselor, and basically what we do as genetic counselors are part of a larger team. We bridge the clinical geneticists, the lab, the patient communities. So we take on board when we send relative letters, we explain to patients, etc. But unfortunately, what I observe is that while research and science is fast moving, when it comes to policy, to legislation, etc., we try to fit in the innovative and scientific findings into old categories. So we are not pushing and making it appealing for more people to study genetic counseling, which is a profession. It's an emerging profession, but in certain countries like France, in the UK, and a lot of other European countries, it's slowly gaining traction. But because first of all, not the community at large do not always know about. We speak about clinical geneticists, nurses, but because we're so few in numbers, we tend to be forgotten, or so we tend to be sidetracked. And it's not appealing for young professionals to take up and study a career which is quite heavy, because you would need to have an undergraduate degree in either psychology, scientific background. Then you need to retrain and do a specific course which is a master's level clinical and medical genetics in conjunction with counseling. So you need to be sort of very specialized and then not be recognized. So we're not, and the need to make it more recognized comes from the policymakers. They need to readjust certain legislations, for example, when it comes to regulating new professions, because we either regulate them and have everything in order, or else we ignore the situation and we leave them, genetic counselors, to work independently of the system and try to find ways where to fit in. So I think have an open mind, even at policy level, and that European legislation is very important. Sorry, I took a lot of
No, it's very important. So what you're saying is you don't feel included as part of the system right now?
It's not.
No, the system is not adjusting to new realities. This is a problem. That's why we need policymakers to work with us in order to adapt the system, the counseling, the specialists who have to communicate with the patients and to communicate with the hospitals and to make all this network working. So we need them to work with us.
Yeah, good, yeah.
Yes, also as European society, we think we see this in many countries happening, and the recognition of medical professions happens in countries, but at the European level, at least there can be some pressure that this is put on the table in each country, because apart from the medical doctors, the specialists who are rather expensive, the genetic counselors can help a lot to see many more patients. And in many countries, you have the clinical geneticists and the lab experts, but especially the counselors can help a lot to bring this to many more people. And still building on that, some countries also feel like the questions of patients are now so much that it might even be possible to build, say, chatbots or online tools to do the first steps of what counselors do, to try to give them some information they need, to try to tell them the questions that they really have to think about, so the counselor could speak shorter to these people. And that's also a development that could be quite hopeful. But as Carla mentioned, we also need to have solutions for people who are not so digitally ready and can really go to all those chatbots, but who just want to see a person to speak to.
Yeah. But I mean, spring Carla in then, I mean, you know, chatbots are interesting because if you see the move towards people using AI for all sorts of purposes today, you know, ChatGPT Health, God on the spot, I mean, Google Doctor has been replaced now. So that is one way to perhaps, you know, that is one thing to tap into, isn't it?
Yes, it is, and I think it's becoming hugely popular. But the kind of information in there is not checked, so to say.
And it's reactive. The agent's
it's reactive
to you.
Yes,
Yeah.
so there are some strategies for hospitals, for instance, to build their own chatbots and around a specific disease group, for instance, and have, for instance, preordained questions. So the chatbot can be used to give an answer, while not giving you all sorts of this distraction from actually what you need to know. So those are good initiatives, and then I think they can be shared, because once you have a good chatbot in one country, in one language, you could use that and for another country and simply translate it, which would save money and investment.
Now, I know that we're sort of running out of time to do, so I just want to bring in one last element with Natalie, and that is, of course, the pharmaceutical industry and their business model built on treatment. So where is their motivation to change?
So I think maybe historically we were built on treatment because diagnosing was difficult, and it was, you know, you saw symptoms and then you tried to treat the symptoms. And I think more and more, certainly the industry that I've witnessed over the last 10 years is going from prevention to care to cure. And I think with more and more emphasis on prevention and cure to actually make the most impact. Because if you prevent, you manage to either avoid the disease or manage the disease so that you don't need a treatment. And if you cure, well, you're cured. So you not only save the patient, but you also save the healthcare system and everything that is involved with it. Whether it's budgets or actually carers who at the moment are under incredible strain. So I don't think the business model today is built on only treatment. I gave those examples when we were talking before about the HPV vaccine, which I wish I'd had when I was small, but you know, my two daughters have had. That would prevent more than 27,000 cervical cancer cases a year, and also save, we calculated, 430,000 hours of nurses. I mean, it's completely awesome. That's prevention. Cardiovascular health checks, whether it's high blood pressure, diabetes, obesity, kidney disease, etc., you can intervene before a heart attack. And if you think that non-communicable diseases are responsible for about 90% of deaths at the moment and rising due to aging populations, you can see how you can really impact enormously the weight that these disease non-communicable diseases have on the loss of life, but also on our healthcare systems. And 60%, I think, of non-communicable disease could be preventable. So there's a massive case for prevention, and I know that the industry is very involved in this as well, and looking into primary, secondary, tertiary prevention, because there are different levels. So I think there you have a you have a partnership that's absolutely possible, but the thing is we can't do it on our own. And that's what we've been discussing all afternoon. It's really has to be from the patient engagement to the healthcare professionals, to the industry, to them to follow up, because prevention doesn't, so you can't just go once and do nothing. I don't do a mammogram once in my life, I can't know for you. So I think there's a whole education, but there's also healthcare systems that need to make it accessible. And I loved your 5 A's that you mentioned. I never heard the 5 A's at the beginning, but they have to also be appropriate. So they don't have to be affordable, but they have to be available. And these are things that not every region, not every country is prioritizing for many different reasons. And I think COVID put all healthcare systems on their knees everywhere. And we never really stopped after COVID to say, oh my goodness, we're strapped for cash, we're strapped for everything. What could we do? Prevention, maybe? What should we prioritize? And that's so interesting to me that we haven't really had that conversation at the level of healthcare systems or regions or ministries of finance, as we were talking at the beginning, to really decide, okay, what do we do next? What would make the most sense? But from an industry perspective, you certainly have the innovation. I think it's a policy decision to prioritize prevention. Yeah.
Okay, lady in the corner, opening up to everyone in the room now. So
Yeah, thanks a lot. Charlotte Monvelto of Redcare Pharmacy, we're Europe's largest online pharmacy and also proud sponsor of this event. Thank you so much for the debate that we've had so far. I really like the comment also about the old and the new systems. I think that's where online pharmacy comes in. And we would never say that it's just online pharmacy and not the traditional brick-and-mortar pharmacies, but rather a complementary model. And there, of course, we need to have acceptance of different systems into the broader healthcare system. And that's also where I really like that the point was raised on literacy, but also AI tools, which are there to support systems. But of course, AI is not gonna judge for us what needs to be done. There still the pharmacist has a very important role to play. And while we talk about prevention, we see prevention in different kind of ways. So prevention can be there at the beginning. However, we should not underestimate the power of prevention when someone is already suffering from a chronic disease. And there, as online pharmacy, we have those tools to really provide that support where we do therapy adherence, medication management. And there, we also need to have the political will, because it's a fact of life. And we've seen it already a couple of times today. It's not a lack of technical solutions that we have. It's more about the political will and the policymakers to have a look at the system to really genuinely do something that is patient-centered, because that is going to help not only the patients, it's actually going to help society as a whole. I'm happy to make that contribution and to have a further discussion with you, because in the end, unfortunately, probably somewhere in our lives, we are a patient or we are being confronted with a patient, among our relatives, for example. So thank you so much for this event organization, and passing back to the moderator. Yeah, sure.
Yeah, I would like to bring a comment. I'm from the Vaccine Collaboration Monitoring in Europe, and we are an international association that was created after a public-private partnership that was that took place years ago. But of course, I would say that vaccines are one of the most important also preventive actions in which industry has largely participated, but also citizens and all these stakeholders are there. And I think that this is maybe more traditional, but of course it takes a lot of trust. During COVID times it was there, but then now it's somehow like, again, the debate is there and we cannot take it for granted, right? So it's very relevant to have this citizen empowerment and not only patient, but citizens, because at the end of the day, when talking about vaccines, it's not patients really only, but it's also citizens that need to support.
Yes, my name is Atabel from Patient Advocate with Is Right to Live and founder of Women Council Europe. Thank you so much for the interesting discussions and knowing that we've gathered here on the occasion of Patients by State, European Patients by State. I first like to know how many patients, not patient representative, but patients are in the room. I'm one. Okay, that's good. How many healthcare professionals in the room? Only two. So that brings me to the point of showing the gap and how much we are talking about patient-centeredness and we are leaving the healthcare professionals out. We need the healthcare professional centeredness as well, because if we're not doing the work in parallel, we will come back to this in a few years and say, oh, we missed that part because we were working in silos. But that's one thing I wanted to bring the attention to. And then the second thing on the citizens' empowerment. I firmly believe in, before that, let me tell you, I'm a pharmacist and I'm also a social political scientist. And I have a lived experience of cancer. So I bring all of this together, but that's to tell you that where is these patients' right? Where is the reachability and accessibility of everything you're discussing here for the patients? If I haven't seen the events on LinkedIn, I wouldn't have known about it. This patients' rights, European Patient Rights Charter, first time I'm hearing this. We could have it at hospitals, clinical centers, so patients would know. And the citizens empowerment, I want to tell you the fact, the truth of the society is that there are many citizens that are already out there, active and empowered. What they need is not empowerment. They're already empowered by their journeys, like me. They need enablers. They need structured funding. And we can put it on policymakers, we can put it on lack of funding, but the reality that pretty much nobody wants to hear is that there is no lack of these two. When the citizens are out there, policymakers will have to are forced to act nowadays. And the fundings are there. The problem is the competition between getting the fundings and not the lack of funding. So we need to bridge this gap instead of just talking the talks and bring the implementation. I have very much enjoyed the discussions, but I also did not get that solution of empowered citizens and actual plans and projects that are happening with patients, with citizens.
Who wants to respond to that?
If possible, yeah.
Thank you.
When Daniela showed the presentation, there were not only related memories for an association, but it was related the memories of a European movement for patients' rights. Hundreds, huge number of associations, patients, citizens, advocates, as you said, in the dark, that is, but advocating every day, and the same, directly or indirectly, were the ones that convinced, in my country, your country, etc., to a large participatory process. Or here at European Parliament to set up for the first time after the European election a Sant committee, a permanent public committee that here at European Parliament that is in charge of on patients' rights. So we need also to remember what we have achieved, because this is important. For our side is important. Here there are leader, representative from association from at least, I don't know, probably 10 member states. I recognize several of you. And collectively, there are more than 50 people from other 13 member states. We should be also proud that citizens more than 20 years ago draft a document, the European Charter on Patients' Rights, that if it's not aware, for your information, has been put last year during the Polish Council of the European Union in the context to be institutionalized and to put the principle of the European Charter in the acquis communautaire at European level. This was another achievement that every day we, with our activity in the dark, with or without economic support, we try to reach. So this is important probably to take in mind some aspect. Thanks.
I think she's right.
Yeah.
I think she's right, yeah. I didn't know about this at all. I just happened to receive an email from ENFA, European National Fibromyalgia Organization.
And you work with
I'm here for the Flemish Organization of Fibromyalgia. And Daniela gave me then, where is she? She gave me then the entrance and I'm here. But I'm hearing you and it's so right, really. Because also the genetic testing, it's all very good. Talk to your family, That's all a normal family. But if you have not a normal family, if you have not contact with your family, where do you stand? Nowhere. the power of the patient. My daughter is in bed, she's 43 years old, she's in bed, she can't move. I don't have a specialist coming to my house because they don't do that in Belgium. I can give you lists in books about the
So
experience.
who would
I
have,
had.
who in the room perhaps would have a solution for that situation? Or an idea of what could be done better?
She was mentioning several problems,
Yeah.
but the problem of not being in contact with your family was by the Dutch patient organization also raised to a kind of a guideline. And they said your clinical geneticists have to send that letter to your family members if I don't have contact with them. And at the legal level, that's not supported. So they, the patient organization themselves told us to be more proactive. And if there is no contact in the family and you know it's relevant for them to send a kind of anonymous patient letter. So they would give you the address or the email, and in some countries that's not allowed. So it's
This is not allowed, no.
No, I know, but yeah, you have to speak to some legal experts also sometimes.
Yeah, and that costs money.
Yeah.
And then it's all about the money.
And then it's also about the willingness and putting it on the political agenda. But yeah.
Yeah.
So yeah, I think that's why there are lots of obviously things that need to be done. Yeah, go ahead, Ian.
Yeah, just one thing about engagements. Among all the things working in a EU project of the one to dementia and infirmity prevention, called Portage. And one thing that we have seen in a very interesting pilot in the UK is that involving the community, they are relying on the biological age basically as a trigger for patient engagement. They don't do that in isolation. They do it in community settings, triggering a discussion and indeed discussing about risk factors, basically, and doing. And that's been extremely well welcomed. We were so surprised to see the number of people who wanted to be tested and to know really what their real age, biological age was, and what they could do in order to indeed have. So we need, I think, to engage the people, tools like that, also which are positive, so that not only negative. But we all know that colorectal prevention is not very successful, although everything is there. It's funded, it's free, but it's not there. But we have the chance here to work on many different risk factors with a positive message. But, and as has been repeated, it needs to take place in other settings than the ones where prevention is taking place today.
Exactly.
Hello, I'm a doctor and I represent medical students. And I just wanted to bring a perspective also that a study that I saw now is that if doctors, GPs were to follow the current guidelines, they would have to work 27 hours a day, 14 of which would be spent on, patients without symptoms. So we need to realize that we have a completely saturated systems for GPs. They are completely overwhelmed. So we need to focus on the most effective things. So I'm just curious, do you have any analysis of the alternative cost? When we provide more guidelines to saturate the systems, we need also to focus on what should we deprioritize. Should it be palliative care? Should it be, there are many things that we are doing. So do you have any analysis of the alternative costs and, how this would improve from the things that are already being done?
Yeah, I can try. Yeah, so basically, I think I don't have of course, I don't have an answer. Otherwise, I would have resolved all the problems. But I think when we talk about the funding, in some sense, treatment and go to prevention, I don't think we have to interpret it as we need to cure less patients. But I think we need to find alternative solutions. For example, I can bring you the example of Italy. And that is not the perfect system, of course. We have a lot of problems, but we recently changed all of our healthcare systems and the proximity systems. And right now we have when you access services from, for example, you have a health problem, so you want more information, you access to it and you talk, before talking to the physician, you talk to social workers, you talk to ask people that are not strictly medical doctor and they can advise you on what to do, because most of the preventive measures that exist, they are already there. It's not like, not some things they need to be added, of course, so I agree with your point, but most of the things, they are already there, and just people maybe just don't know. Let's talk about vaccination, for example, just to give you the most basic prevention measure. So vaccination, they are already there. We have the laboratories, we have the physician that do the vaccination, we have the vaccines, but we just reached 60% of the population. So if we want to reach 100% of the population, we already have some screening, for example, we were talking about screening. Of course, for example, for the colorectal cancer screening, we are already the pipeline, but the pipeline is feasible to absorb all the population. So we need also to work on the proximity and to reach all the communities and bring the communities towards us. Or we need to go to the communities, but we need to merge these two aspects. And we don't have to ask the general practitioner to do double their work, because it wouldn't be feasible, and it wouldn't work.
Yes, for example, in our standards of care, for example, very specifically in muscular dystrophy in Romania, we don't have genetic counselor, we don't have time for the doctors who are overwhelmed, really. So in our standards of care, we promote the idea that when a new patient is diagnosed, we send, meaning the genetic specialist is sending the patient to the patient organization, to the specific patient organization who takes care of counseling, of pilotating the patient through the system, to inform him about the consequences, and a lot of other activities. So we promote this in the standards of care to send the patients when we don't have resources to specific counselor for experienced patients.
Okay, unfortunately, I think we're going to get kicked out very shortly because I feel like there's someone in the thing. So I'll hand over to ACN and just to say, whoever's been tapped up for an interview for the actual event video, please do stay with us. And ladies, I'm going to interview as well. I'd like to interview as well. I had no from Bianca. Bianca, did you have something to say? Go for it, Bianca. Go for it.
It's just a very big comment.
Yeah.
Regarding the involvement of ministries of finance and DGFIN, for example, about healthcare studies. Over the years, we tried several times to get them involved in this kind of discussions, and every time we were answered that healthcare is not among their competency. So probably here the problem is something else. There's a bit of confusion.
Yeah, the problem isn't in this room, it's outside the room.
Exactly. It's
not
enough.
Yeah, massive. Mariana, please, to take it down, and please continue the discussion outside as well.
Just 1 minute. We welcome that prevention is a key high priority by the European Commission. We can identify personalized prevention that is much more than only technology, because it's related as a transformative approach related to the next, the future relationship between the civil and the national system. We are aware, of course, of the, as Luigi said, risk of discrimination. So we need to avoid inequalities. We need to avoid that personalized prevention can be reduced for an opportunity or privilege just for few. So we have a responsibility to share responsibilities in order to guarantee that the evolution of the patient's right to preventive measure could work in the direction to be more equitable, more participatory, more human, not just more sophisticated. In this context, initiative like Prophet can work matters so much, as it helping to build a European model for preventing that combined innovation with democracy, legitimacy. Of course, the point is the implementation. The point is, of course, resources, but in a very broader sense, equitable access, clear communication, and literacy. One of the points is active role, active and informed citizens and patients. My question is always the same: who is in charge to provide health literacy for all of us? Which is the entity that is entitled to guarantee health literacy for all of us. Is there in your country, my country, a national program on health literacy, like there is the national program for fighting AMR, to support publication, vaccination policy, non-communicable disease, etc. So we need to also leverage this aspect in front of the institutions. Some next step, because of collective actions, it was one of key words. I'm pleased to invite you to the Prophet Final Conference. It take place here again in Brussels, 8th of July. My organization tomorrow we organize a dedicated event on personalized prevention in immunology and vaccination. As already mentioned, it was the key aspect when we talked about prevention, the role on vaccination. I have my list of acknowledgements, so I have to start to thank you all of you. There was more than 50 joined remotely. Some of their received the flight cancellation to the strikes. It was impossible for them, for some of them, to join in person. Thank you to the hosting map Benifei, the colleague that endorsed involved in the European Patient Rights and Cross-Border Healthcare Interest Group that endorsed this initiative. Of course, thanks to the European Commission. Thanks, Mariam. All the speakers for very high quality of the debate. A special thanks to the Prophet Consortium coordinator and to all the partners. Thanks, Daniela. Thanks, Bianca. Thanks all my colleagues based in Italy. I just want to mention that the event was made possible thanks to the EU-funded Prophet project, to the unconditional support of MSD, Redcare Pharmacy, and Viatris, who I would like to sincerely thank. Thank you also to our 3 media partners, Health Europe, Trend Sanità, and Pubtexo Publishers. Just for remind that all the presentation will be published in our website, sharing through our newsletter. See you next appointment. Thank you so much.
Thank you. Bye.
So we all get picked up.